So this is an 80-year-old patient, and with severe aortic stenosis. Also, of course, he's known with arterial hypertension. He presented actually with dyspnea, angina, CCS2, and on his echo, he has an ejection fraction which is preserved, 60%. He has high gradients, mean gradient of 55, an AVA of 0.7 square centimeter. And then he had a coronary angio. That showed actually a closed intermediate vessel. He had a stenosis on the LAD, which was RFR apparently negative or what? Yes, he was positive because it was 0.69. He got PCI of the LAD before, and now he's on double antiplatelet therapy. And then his renal function is preserved. His ECG looks fine. PR is normal, 140, QRS 104. And then on the anatomy, he has a very calcified tricuspid aortic stenosis. Just to give you some idea about the sizing, he has a perimeter-derived mean diameter of 25.5. Tricuspid, as said, coronary heights are all above 12 millimeters, so no concern for that. The aortic root angulation is kind of neutral, 45 degrees or 50 degrees. Well, actually, there's some little touch of horizontality in it, yes, okay. And then the axis is pretty calcified. We were just busy with it. There's some calcium. It's for sure enough. The dimensions are large enough, but we store a tiny bit with calcium. So we did just the axis, okay. And the valve choice here is going to be an Acurate. An Acurate large. It fits for the 27 millimeter. So what we did here right now, so this is TAVI and local anesthesia. Patient has no conscious sedation, no general anesthesia. Maybe we can show on the fluoro, if you see the fluoro, what we did in this particular case, because we broke one style on the left, clearly there's calcium on the puncture site on the right, which is not favorable for the main axis. So we decided to go on left for the main TAVI axis, but there we had some issues with breaking the suture with the ProGlide or Pro style deployment. So in order to build some extra safety, we decided to use, which is rare, I think we do it in less than 1 in 20, 1 in 30 cases, but to use some kind of safety wire contralateral. So that's what you see on the fluoro. You see a contralateral safety wire going from the right leg to the left. It's just if we would have an issue with the vascular closure at the end. So we're just there. We haven't done anything else so far. So just the axis, and now we're going to continue with main axis. Yes, we're going to scale up to the eye sleeve. That's the 14 French eye sleeve, which is the sheet that's suitable for and is used for the Acurate platform, the Acurate valve. So you're gonna need the stiff wire here. Yeah. Okay. Heparin is given. Yeah, good. And because the patient, he has calcium everywhere, he's pretty calcified, access, aortic arch, etc. We're gonna very calcified leaflets. We're gonna use some cerebral protection as well here in this particular case. Yes. So now we're preparing to get the large access in the 14 French. It's an expandable sheet. And this sheet, to give you some more side information. It's in a sheet which is compatible with many valves. You can use any self-expanding platform to deliver these valves through the eye sleeve. Only exception is the Evolute 34 Pro Plus, which does not fit in, but all the other sizes of Evolute fit in, all Navitors fit in, all Accurates fit in through the eye sleeve, the expandable sheet. So Alejandro, as soon as yeah, okay, that's good. Yeah. So the people doing the case here now is Alejandro is standing as the first operator, our fellow, and then we have Nick. He's our senior fellow. He's also as a second position there. All right, we connect to the pressures. This one, yeah. All right. You're gonna put the L1 on now, just to get this over the arch, and that will align the aortic arch, and that's we're going to use then to deploy the sentinel as well. Yeah, you see the aorta even without contrast. You see, so there's a lot of calcium there. So I think it's justified to use sentinel here. Yeah. Okay. Good. That's it. All right. Syringe just on it. I'm here with the Sentinel for you guys. So Sentinel goes in through the 6th French right radial. Wire goes smooth. That's good. Okay. Okay. All right. Let's move on. Let's flare a little. All right. The wire is there already. Keep hold of the wire, please. I'll zoom one in, maybe. Yeah, there it is. You have to go to the ascending aorta, yes? So pull that back, the wire a little bit, please. Yeah, that's good. All right, that's nice. Maybe because I saw it on the CT, these vessels are pretty much close to the valve. They're not really on top of the arch. They're like, I'll open up the arch more even. I think this maybe a tiny bit lower, and then you're almost in a good position to deploy the first filter. Yeah. Okay, you can go ahead. So there's a nice marking on this Sentinel device. You have knob 1, 2, and 3. You just follow this chronologically. So knob 1 is deployed. That's good. And the most proximal filter is out. With knob 2, we're going to flex. I would pull back a bit because your first filter is hanging on the aorta. Yeah, that's good. All right. Now we're going to flex with knob 2. Yeah, we turn it clockwise. Keep on going. Keep on going. And now you have to turn the whole handle, not the knob, but the handle. Yeah, okay, you can start coming out with the wire and see where it goes. All right, so flex more and split the handle more. And now you can push out the distal filter. Bail on the wire, please. Keep on going. Yeah, go, 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 go. That's good. Okay, so then we are ready to actually kind of cross the valve, I guess. Yeah. We're going to bring in the pigtail a bit later here. So now bring in the pigtail. Of course, we occupy the radial artery for the Sentinel, so we just bring this in by the contralateral leg pigtail. Yeah, that's good. We had expected it to be there, of course. NCC, non-coronary cusp. There's some horizontality in it. I think we miss some high, but then sometimes the L2 doesn't make it necessarily better, you know? Yeah, it's more indeed higher up. It's actually very vertical annulus, which is a bit tricky, I would say, for valve placement too. It was a little lower than we thought, but the horizontality is the problem here. Now go really deeper in with the wire. Okay, so what we're gonna do now, what we always do routine, we're gonna change the pigtail into the LV. You can decide just to push your AL1 in and come out with your stiff wire, which is gonna be a safari here, right out of the L1. I would say, yeah, you can do it for sure. 98% of cases good, but you take a little more risk. It's more aggressive to come out with a stiff wire. You can be more perforation. It also gives you better possibility to do proper hemodynamics with the pigtail. So we like to change it to the pigtail just to assure you're out of the mitral chordae to do a proper hemodynamics measurement. So now we push the pigtail in. Yeah, that's it. That's good. Let's do some hemodynamics. So peak to peak 54 in VT, and we have end-diastolic 25 and 63. Yeah, good. So he's not on the dry. He's not too dry. He's preserved the action fraction. So I think he's euvolemic. He's not underfilled. He's not too much overfilled. I think it's good. We don't do anything special here with the fluids. So are we ready for everything? Yeah, we have everything in place. Sentinel is in place. We have the pigtail in place. So now we're going to go with the stiff wire safari, and then we're going to do the pre-build. Yeah. Yeah, we are going to pace here. Yeah. Yeah, please, indeed. But let's not go too low with the balloon, please. Not too deep into the LVT. That's good there, probably. I would push maybe a bit in again. Like, all right, that's good. Okay, guys, you coordinate for the balloon. Yep. That's good. That's just a gentle one. Yeah, that's good. Stop pace, please. Yes, good. Stop pace, please. I think that was a good, proper predel, and he has a good preserved rhythm, so we can walk it out. This is the tricuspid view. And let me see. Tricuspid view, white. It looks good to me. Yeah. Okay, we can stay in this angle for now. Yep. All right. But here you see clearly it's, yeah, we have the very vertical analysis. So there's a small loader, and Alejandro pushed that a little bit in. Now he pushes 30 centimeters device in, and then after that he will pull back on the loader. Yeah, you have needs a little bit of force. Okay, loader back. We can park the loader there. Okay, slowly, guys. Yeah, pressure is there. Yeah. You can cross the arch and then I will take over. Yeah, enable auto. Because I mean the placement is a bit more tricky as it's we'll have to be very. Yeah. Valve is correctly loaded. It's a good thing. Okay. I think I will step in if I'm here. We have to be very precise here, I think. Let's try to do that. Patient has to lay very still too. It's important. All right, good. I'm almost there where I want to be. Huh? Like I wouldn't go lower than this for sure, I think. So we check it. Yeah, we're almost there. If we cannot push it lower because then the upper crown will be below the calcium. So I think this is the right moments to start opening knob number 1 carefully and slowly. Yeah. With the final deployment, we can go. Yeah, that's good. So upper crown is above the calcium. That's a good thing. I like. You slowly continue. I build up already a little bit extra push, 5 millimeter with the catheter. Yeah, it's good. Right. All right, let's space maybe 140. Can we do that? Pin out, please. Okay, give me the chance to push still. I'm definitely gonna push. Yeah, push 5 more millimeters. I'm quite a lot on the other curve. What? Well, don't lose the time with that. Okay, I'm still gonna. But you see on the wire, I have a lot of push, but I'm still gonna push 2-3 extra millimeters. And don't pull on the system. Do not pull on it. Yeah, I give extra push. Now I have a lot. I think you go now. Yeah, go very quick. Quicker. All right. Be careful. A 12 French sheet, please. Oh, we have to be careful. Yep. Oh. And the wire is just. So what? Yeah, all right. That's good. That's fine. So what we're gonna do is we're gonna take, but maybe that's safety wire. Then we have to drop that idea for now. So then a pro style, and then we blade, please, also. Maybe I should do amateur. Otherwise, we can just remove that one too. That's also an option, yes, that we can just upside it. That's another, but I don't want to kind of lose the other access, if possible. We need just an access. Yeah. All right, good. So what we're going to do is, while the valve has gone off from the catheter, but catheter is still in the LV, we're just going to cross the valve again and then dilate it up with a balloon so that it's we get the valve of the more expanded. Yeah, that's the whole idea. All right, so now we have to, no. And then, of course, crossing the Acurate is also, we have to follow some specific rules there. It's not the easiest, but let's manage to do it. But we have to be careful. You hold the wire. Hold the wire, please. Yeah. Give me then a J wire. Yeah, all right. Okay, now we cross the valve, but it should be at the inside of the valve, and that taking, of course, here. how to do that. Okay. Turn it out like this. You have to be in the frame and cross it. Yeah. But that we're not there yet. Now it's the matter of proof of the pudding. We have to overlap both arches. Oh, it's very constrained, huh? So now we have overlap bolts there. Yeah. And now we have to make sure that we're not on the outside of the so I have to be able to push this. I think it is. We have to be 100% sure. That's the point. Let's go with 7.5. Yes, sure. Disabled. Yeah. Okay. Let me see if I can play. So we have to be able to push the catheter normally on the left side of and then on the inside of the overlapping arch. I think it can almost not be that I'm in the center. All right, good. Then step wire, please. Yes, Safari. Wait, let me push. Can you hold the wire? I'm going to push it just a tiny bit lower. Just a bit away from my valve. You're not really. Don't poop really too much. Let it go a bit. Yeah, that's better. All right, good. Balloon is ready, please. We need very, very good pacing. Absolutely. Yeah. Somebody holds the wire, please. Hold the wire, please, Alejandro. I'm going to position it officially good, like to the mid of the post. Like there. Yeah, all right. Now I'm going to push this a bit deeper. Can somebody hold this here? I'm going to push this so it's as much as possible out of my way without perforating the LV. Yeah, okay. I think it's fine. So we only go up with the balloon if the pressure is down. Yeah. Not full capture. Stop pacing for now. Maybe try 200. 200 pacing on. Be ready. Okay. Quick up. And down. Stop pacing. It's good. It's good. Okay, now we can still, it's good. Everything is fine. I think this, we do not need anymore. Everybody agrees? This balloon, we can pull out. So this, we get rid of. And now we just do the classical way, okay? Everything out here. Don't come out, do not come out with the wire head. Wait. Okay, come out with the wire, please. More. Yeah, all right, that's good. All right, that's fine. Okay, but okay, it was interesting to show how you can save this and how you have to do it. Now, number 2. That's the way to do it. But it's not for rookies, I would say. Yeah. Okay, good. Stop. We take it out. Yes. Okay, let's move it out. And then we see what we have. If we have to pulse a little more, we didn't go all the way, but this pressure is very nice. The patient stayed completely stable throughout the entire procedure. It looks very promising.